Welcome to Phoenix Medical Lectures. In today's video, we'll be seeing about rheumatic fever. Rheumatism is the inflammation of joints, muscles, and fibrous tissue. Rheumatic fever is caused by group A beta hemolytic streptococci. Group A beta hemolytic streptococci releases streptolysin. Streptolysin is responsible for the rupture of RBCs, which is called beta hemolysis. The course of the disease is that first, streptococcal pharyngitis occurs, which leads to rheumatic fever. Streptococcal pharyngitis is the inflammation of the throat due to Streptococcus pyogenes. Coming to the pathogenesis. So Streptococcus pyogenes contains an M protein. This M protein is highly antigenic. This makes the immune system to recognize it as a foreign body. Due to this, antibodies are produced against the M proteins. These antibodies tend to act against the body's own cells. This is a cytokine mediated inflammatory response. Which leads to tissue damage. This entire phenomenon is known as molecular mimicry. This is a type 2 hypersensitivity reaction. Coming to the clinical features. The first clinical feature is migratory polyarthritis. Here, migratory means one after the other. Polyarthritis is the inflammation of multiple joints. So this is the first clinical feature. It causes migratory polyarthritis, which is the inflammation of multiple joints one after the other. The second feature is Pancarditis, which means the inflammation of all three layers of the heart. The three layers of the heart are endocardium, myocardium and pericardium. We'll see one by one. Endocarditis is the inflammation of the inner lining of the heart, along with the valves. So endocarditis is the inflammation of the inner lining of the heart along with the inflammation of the valves. The most commonly involved valves are the mitral valve and the aortic valve, among which mitral is the most commonly involved. The second one is myocarditis. Myocarditis is the inflammation of myocardium, which is the heart muscle. Myocarditis is the inflammation of the myocardium, which is the heart muscle. The inflamed area in the myocardial tissue contains Ashkoff body. This Ashkoff body is a characteristic feature of Pancarditis. The Ashkoff body contains areas of fibrinoid necrosis. It also contains immune cells, which are T cells and Anishkav cells. These Anishkav cells are enlarged macrophages which contains a caterpillar looking nucleus. So myocarditis is the inflammation of the myocardium, which is the heart muscle, which contains inflammation in the myocardial tissue, which is the Ascough body. The Ascough body is a characteristic feature of the Pancarditis, and it contains areas of fibrinoid necrosis and also immune cells, which is T immune cells and Anishkav cells. These Anishkav cells are enlarged macrophages which have a caterpillar looking nuclei. In acute rheumatic fever, myocarditis is the most common cause of death because the heart cannot contract, leading to heart failure. The third one is pericarditis. It is the inflammation of the outer lining of the heart. Pericarditis is the inflammation of the outer lining of the heart, and this causes pain and friction rub. Between the visceral pericardium and the parietal pericardium. The next feature is subcutaneous nodules. These are painless, firm lumps which are made up of collagen. Subcutaneous nodules are painless, firm lumps under the skin which are made up of collagen. They are normally found in the back of the wrist, outside the elbow, and in front of the knee. The next feature is erythema marginatum. This is a rash present in ring shapes. This is usually present on the arms and trunks, and it is non-itchy. The next feature is Sydenham chorea. This is also called the Saint Vitus dance, and this causes rapid, jerky movements of the face and arms. This rapid, jerky movement caused by Sydenham chorea is due to the autoimmune reaction against the basal ganglia. So Sydenham chorea is a rapid, jerky movements in the face and arms, and it is caused due to the autoimmune reaction against the basal ganglia of the brain, and this appears later in the disease, at least 3 months after infection. Coming to Jones criteria, according to which a person is diagnosed of having rheumatic fever if there is evidence of previous group A beta hemolytic streptococcus infection plus 2 major criteria or 1 major and 2 minor criteria. So first we'll see the major criteria. So the major criteria are all the clinical features that we have seen, which is migratory polyarthritis, Pancarditis, subcutaneous nodules, erythema marginatum, and Sydenham chorea. Now we'll see the minor criteria. which are fever, joint pain, and increased acute phase reactants. Acute phase reactants are proteins that increase in the blood in response to inflammation, which is increased erythrocyte sedimentation rate, increased C reactive protein, and increased white blood cells. We'll have a quick revision of the Jones criteria. According to the Jones criteria, a person is diagnosed to have rheumatic fever if there is evidence of previous group A streptococcus infection plus two major criteria or one major and two minor criteria. So the major criteria are polyarthritis, pancarditis, subcutaneous nodules, erythema marginatum, and Sydenham chorea, whereas the minor criteria are fever, joint pain, and increased acute phase reactants, which are increased ESR, increased CRP, and increased WBC. Now, coming to investigations, the first one is evidence of a systemic illness, which includes increased WBC, increased ESR, and increased C reactive proteins. The second one is evidence of a preceding streptococcal infection. So the first one is a throat swab which contains group A beta hemolytic streptococci, and the second one is an ASO titer, which is the anti-streptolysin O titer, which is commonly increased. So it is more than 200 in case of adults and more than 300 in case of children. The third one is the evidence of carditis. So in chest X-ray, there is presence of cardiomegaly and pulmonary congestion, and in ECG there is AV block and T wave inversion, and in echocardiography there is cardiac dilatation and valve abnormalities. So coming to treatment, the first one is rest, the second one is anti-inflammatory and antipyretics, and the third one is antibiotics. The major anti-inflammatory drugs used in the treatment of rheumatic fever are aspirin and steroids. First we'll see about aspirin. So the starting dose is 60 milligrams per kg body weight per day and not exceeding 8 grams per day, and this is given in 6 divided doses. So aspirin should be continued until the ESR has fallen. The common side effects of aspirin are nausea, vomiting, tinnitus, deafness, tachypnea, and acidosis. Coming to steroids, steroids are indicated in carditis and severe arthritis. Prednisolone 1 to 2 mg per kg body weight per day is given in divided doses. This should also be continued until the ESR has become normal. Coming to antibiotics, residual streptococcal infection is treated with benzathine penicillin 1.2 million units as an intramuscular injection once, and phenoxymethylpenicillin is given orally 250 milligrams 4 times a day for 10 days. For long-term prophylaxis, benzathine penicillin 1.2 million units is given as an intramuscular injection monthly, and phenoxymethylpenicillin 250 milligrams is given orally twice daily.